Okay, the next item of business is a debate on motion 15382 in the name of Jenny Minto on the Women's Health Plan 2021 to 2024, progress and next steps. I'd invite members wishing to take part in the debate to press the request to speak buttons now or as soon as possible. And I call on Jenny Minto to speak to and move the motion. Minister, around 13 minutes, please.
Thank you, Presiding Officer. Women's health is an area I'm extremely passionate about, so I warmly welcome this debate and the opportunity to bring this important topic back to the Chamber. We know that women's health isn't just a women's issue. When women are supported to lead healthy lives and fulfil their potential, everyone benefits. Women make up 79% of our NHS workforce, 89% of our teachers, 80% of our social care workers, 59% of our unpaid carers, and 92% of single parents. To prioritise women's health is to prioritise the health of Scotland. However, we know that women and girls face inequality and disadvantage because they are women. This has to change, and we are determined to create the conditions we need to improve health outcomes for women and girls. In August 2021, Scotland became the first nation in the UK to publish a plan for women's health. The plan's ambition, and I hope the ambition of all of us here today, is for all women and girls to enjoy the best possible health throughout their lives. The first phase of the plan focused on a set of priorities where there are particular inequalities for women, such as heart health, and where women told us improvements were needed, such as action around menopause and menstrual health. Healthcare professionals, academics, third sector colleagues, researchers and, most importantly, women came together to inform the plan. And I am pleased that we've been able to make progress in implementing the actions of the Women's Health Plan during what has been and continues to be a challenging time for NHS Scotland and for all our public services. 3 years on from the publication of the plan, it is right that we take stock and reflect. To do that, I would like to highlight just a few of the achievements of the past 3 years. In January 2023, we appointed our Women's Health Champion, Professor Anna Glazier, OBE. This was an important milestone in the progress of the Women's Health Plan. I'm very pleased that Professor Glazier is joining us in the Chamber today. Professor Glazier has had a long and distinguished career in women's reproductive health, and as champion she plays a pivotal role in raising the profile of women's health, sharing her unparalleled expertise and challenging the status quo. I would like to thank Professor Glazier for being our Women's Health Champion, for her leadership and her passion for driving change and innovation, and I am delighted that she has agreed to remain as Women's Health Champion, ensuring continuity into the next phase of the Women's Health Plan. In addition to our Women's Health Champion, we now have a Women's Health Lead in every board. The leads are able to highlight issues impacting women across Scotland, enabling national responses. Most recently, they have focused on improving access to longer-acting reversible methods of contraception, known as LARC. During the development of the plan, something we heard consistently from women was that they wanted a reliable source of information on women's health. In response, we launched the Women's Health Platform on NHS Inform in May 2022, providing new resources on menopause and menstrual health, including myth-busting videos, information on symptoms and options for care. The platform offers women and girls access to comprehensive and reliable information. As of last month, there had been over 2.95 million views on the menopause pages alone. The importance of information on menopause was particularly illustrated to me in April this year when I visited the Maggie's Centre in Edinburgh. I met with a group of women experiencing treatment-induced menopause. They described to me their personal experiences of menopause during their cancer journey and the importance of good quality information on treatment-induced menopause. It was a privilege to spend time with these women, and I am very grateful that they felt able to share their experiences. As we move to the next phase of the Women's Health Plan, I hope we can continue to learn from women's experiences and the work organisations such as Maggie's do to do even further in our support for women and girls. We know that endometriosis affects 1 in 10 women, and that is why it featured as a key priority in the Women's Health Plan. Last year, the Centre for Sustainable Delivery published the Endometriosis Pathway for Scotland to improve women's access to diagnosis and care, and I was delighted to visit the Endometriosis Specialist Centre in Aberdeen a couple of months ago to learn more about how the pathways work in practice.
Rachel Hamilton.
Thank you, Presiding Officer, and thank you to the Minister for letting me intervene. The Minister met me and endometriosis campaigners last April, and the Minister looked at a policy paper from the Scottish Conservatives regarding ways to improve access to endometriosis treatment. She also committed to bringing down the waiting times, which is currently, on average, 8.5 years. I was wondering if she has any updates that she can provide to the Chamber.
Minister, I can give you the time back.
Rachel Hamilton for her intervention and also the work that she has been doing specifically in the borders around endometriosis diagnosis times. And I do recognise that diagnosis times are, for endometriosis are too long, and we need to find ways. And I think that was one of the benefits that I had of meeting with the staff at the centre in Aberdeen and across the Health Board, because they are passionate about supporting women who live with this challenging condition to access high-quality care. And as part of the work that we've done, we've jointly funded a £250,000 research project with Wellbeing of Women, which aims to develop a new treatment option for endometriosis associated pain. So we've still got work to do, I recognise that, but it's certainly on our radar. Presiding Officer, there has also been progress in a range of other areas. A specialist menopause service has been established in every mainland health board, and a buddy support system is in place for island health boards. We have worked with the University of Glasgow on groundbreaking research, asking women working in NHS Scotland about their experience of menstrual health and menopause in the workplace. Based on this research and the views of over 6,000 women, we published a menstrual health and menopause workplace policy for NHS Scotland. Our recently published Women's Health Plan final report provides more detail on the 3 years of implementation. The report is importantly published alongside 2 companion pieces, a review of the data landscape and a report by the Health and Social Care Alliance Scotland on their lived experience programme, a key part of the delivery of the Women's Health Plan, ensuring women's voices are at the heart of our work. Once again, I would like to note my thanks to everyone involved in delivering the first phase of the Women's Health Plan. It has been a nationwide collective effort. I would particularly like to thank those in the Chamber who continue to advocate for the health of women and girls. I really value the input we have had from many members, and I hope that we can continue in this spirit of collaboration and joint effort as we move into the next phase of this essential work. It's important to highlight, Presiding Officer, that the Women's Health Plan does not exist in isolation. At 51.4%, women make up the majority of our population, and women and girls have particular needs that need to be addressed across the breadth of health policy. Work is being undertaken across the Scottish Government and the NHS to progress improvements in women's health and their access to healthcare services. Maternity services have a key role to play for women supporting their health throughout and after pregnancy. The Best Start is our plan for putting women, babies and families at the centre of maternity and neonatal care. We want all women and their babies in Scotland to receive the best and safest care possible at all times. Working in partnership with NHS boards, including Healthcare Improvement Scotland, clinicians and women, we are committed to continuous improvement in maternity safety. Sadly, of course,
Jackie Bailey.
I'm very grateful to the Minister for taking an intervention, but I think it's clear to say that when it comes to specialist neonatal services, the consultants, all the clinicians and the women involved are actually opposed to the Minister's determination to withdraw specialist services from Wishaw Maternity.
Minister.
Jackie Bailey for her intervention. However, the advice that we have been receiving is from experts in the clinical field, and the visits that I have had, as well as Bliss, who advocate for parents, all support the reduction in neonatal intensive care units in Scotland. Sadly, pregnancy doesn't always go the way we would want it to, and the loss of a baby, no matter at what stage of the pregnancy, is a traumatic experience that can have a profound impact on families. Improving miscarriage care and support for women across Scotland is a key priority for me, and we will shortly publish a miscarriage care delivery framework to help NHS boards drive progress and focus on areas where improvement is required. Last year, we launched a memorial book and certificate for those who have experienced pregnancy or baby loss prior to 24 weeks, because we know that for many parents, formally recognising the baby they lost provides some comfort and validation during an incredibly painful time. This service is free of charge, completely voluntary, and historical applications are welcome. More information on how to apply can be found on the National Records of Scotland website, and I would like to thank baby loss charities such as SANS and Held in Our Hearts and others for their considered support in this. Presiding Officer, the Government is also determined to see the end of cervical cancer. The World Health Organization Director-General has announced a global initiative to eliminate cervical cancer, and we are dedicated to supporting this vital cause. And as I set out in Parliament in January this year, we've already taken positive steps. We've established an expert group chaired by Professor Glazier and 3 working groups which will focus on HPV vaccination, cervical screening and cancer treatment. Good progress is being made through the HPV vaccination programme, and recent research undertaken by Public Health Scotland in collaboration with the Universities of Strathclyde and Edinburgh shows that there have been no cases of cervical cancer in fully vaccinated women who received their full course of HPV vaccination aged 12 and 13 years old. So, Presiding Officer, the message to girls and young women is clear: get vaccinated. Elimination of cervical cancer is within our grasp. Let me now move on to abortion. On the 24th of September this year, the Abortion Services Safe Access Zones Act 2024 came into force. The Government was pleased to support the bill brought forward by Gillian Mackay, and I'm sure women across Scotland were encouraged that the bill won support from across the Parliament. It has long been the Scottish Government's ambition to ensure that Scotland is a place that people can look to as a beacon for women's rights. The Women's Health Plan committed to a review of abortion services in Scotland. This is to ensure services are meeting the needs of women. We want abortion to be seen first and foremost as a healthcare matter and a way by which women make their choices over their health. Presiding Officer, this is just some of the work we're doing to improve the health of women and girls. I'm proud of what we have achieved together, and I look forward to what will come next. Supporting women and girls to enjoy the best possible health throughout their lives will continue to be our guiding principle as we develop the next phase of the Women's Health Plan. We know it's still the case that many women and girls do not enjoy the best possible health. We know there are women and girls living in poverty, where inequalities are even greater, and I acknowledge here today that we must do more to address them. This is not something I have shied away from, and therefore I am happy to support Carol Mochan's amendment. To further achieve our ambition for women and girls in Scotland, we will look at what has changed in Scotland, both positively and negatively, since August 2021, build on the plan's existing priorities and reflect on where additional focus is needed. We will consider the many factors that make up a healthy life, asking what we can do better or differently to support women and girls of all ages and stages of life. Over the coming months, we will continue our conversation with women and girls, healthcare professionals and academics and the third sector across Scotland to ask what they want to see in the next phase of the Women's Health Plan. We will review and update our evidence base, ensuring any future work is grounded in the most up-to-date research. Early discussions indicate women would like to focus on pelvic health, bone health, postmenopausal health and ageing well, and weights for gynecology care and treatment. But we're just at the beginning of this work, and I look forward to hearing proposals from members across the Chamber today. Presiding Officer, to conclude, it is a huge privilege to hold the position of Minister for Women's Health. To be able to listen to women and girls across Scotland and hear about their ideas and ambitions as to what can be done differently so all women and girls experience the best health and healthcare throughout their lives. I look forward to today's debate and hope that across Parliament we can find common cause to support that ambition. Presiding Officer, I move the motion in my name.
Thank you very much, Minister. I now invite Annie Wells to speak to and move the amendment 1538 2.1. Around 9 minutes, Ms Wells.
Thank you, Presiding Officer. To begin with, I would like to thank the many organisations that have provided briefs for today. Health is one of the biggest issues on the minds of people across our country, and this is no less true for women, who have their own unique health challenges and needs. The Women's Health Plan was first published in 2021 by the SNP Government, and it sets out to address women's health inequalities and the serious barriers preventing women and girls from accessing the healthcare services and support that they need. This plan included 66 actions focusing on heart health, postnatal contraception, menopause, endometriosis, menstrual health, abortion and contraception. And we all know women's health needs like these are present and evolve throughout each woman's life from adolescence to their later years. And because each woman is different, health policy must be aimed at adopting an approach which accounts for the disparities and barriers they face in accessing sufficient healthcare services. In the SNP's own manifesto from 2021, several commitments were made to improving women's health. These commitments range from reducing endometriosis diagnosis waiting times and establishing a new Scottish Institute for Women's Health, to improving access to services helping women through the menopause diagnosis and management. And I do welcome the £250,000 that the Minister has said has been put forward for endometriosis. But despite the manifesto commitment, the SNP and the Women's Health Plan, healthcare services support and most importantly health outcomes for women have shown a downward trend under the 17 years of SNP mismanagement. And how are women being failed by the SNP government? Let's simply look at the numbers from some of the most crucial areas in women's health discussion. There are ongoing failures in addressing issues surrounding endometriosis, women's heart health and cancer care that have devastating impacts on the women they affect. For example, 58% of women said they saw their GPs 10 or more times prior to an endometriosis diagnosis because of symptoms, and with 53% also doing the same with A&E visits. And as my colleague Rachel Hamilton pointed out, even when a woman is finally able to be diagnosed, it's taken on average nearly 9 years to get a diagnosis in Scotland. That we are talking about women waiting almost a decade to just receive a proper diagnosis, and that's not even including the time it takes to begin treatment. And on the issues of women's heart health, the situation is not any better. The British Heart Foundation notes that 2,600 women die each year in Scotland from coronary heart disease. And this makes coronary heart disease the single leading killer of women, even more so than breast cancer. And moreover, the charity Chest, Heart and Stroke Scotland has found that for every day that passes, there are 10 women who die from heart disease and heart attacks across Scotland. And there are also 95,000 women across the country who are living with coronary heart disease. And I'm highlighting these numbers at a time when waiting times for cardiology have hit record highs. This has resulted in less than 3 in 10 Scots being seen within the ECG's 6-week waiting targets, with 1,200 people even being forced to wait more than a year for an ECG. And this brings me to the Scottish Government, the failures of the Scottish Government relating to women's health and cancer numbers. While the Women's Health Plan Progress Report said that it wanted to take an intersectional approach to account for each woman's life to ensure the best outcomes, the truth is opposite. Women from the most deprived areas across Scotland were less likely to get screened for breast cancer in 2022-23 and cervical cancer from 2021-22. And on the issue of breast cancer specifically, the charity Breast Cancer Now said that breast cancer is the most common type of cancer in the UK, with almost 4,770 women diagnosed annually. And they also said that the Women's Health Plan brought by the Scottish Government was an opportunity to improve breast cancer outcomes through doing things like reaching the 8% breast cancer screening targets and increasing breast awareness. But the Women's Health Plan was an opportunity to help women overcome barriers and inequalities to receiving the highest standards of care and support, but the potential has not been fulfilled. The numbers are shameful and continue into another area that had important effects on women's health, and that is alcohol consumption and misuse, and that has on breast cancer health outcomes for women. And according to Alcohol Focus Scotland, in Glasgow alone, 16% of women drink more than the guidelines set out by the Chief Medical Officer. This has a potential to significantly affect women's health relating to developing certain types of cancer. Just drinking about half a pint of beer or a small glass of wine daily can increase women's risk of developing premenopausal breast cancer by 5%, and for postmenopausal breast cancer it's even greater, with the risk rising by 9%. And what's more, women often face barriers to accessing alcohol addiction support services, and there remains a good deal of stigma around women that misuse alcohol. Adding to this, in 2022 to 2023 in Glasgow, only 26.5% of people with learning disabilities who were eligible for cervical cancer screening went to their appointments. Unfortunately, this grim picture carries over to women's life expectancy. Scottish women have seen it fall lower than it was before the COVID-19 pandemic, standing at 80.9 years from 2021 to 2023, compared to 81.1 prior to 2021. In fact, not only is Scotland ranked lower than other nations in the UK for female life expectancy, but it is now also ranked 22 out of 29 nations for female life expectancy when compared Europe-wide, and that's according to the National Records of Scotland. To conclude, Presiding Officer, the Scottish Government launched the Women's Health Plan 2021 to 2024 with the aim of tackling health inequalities and poor health outcomes faced by women, and changing its approach taken to women's health. But the Scottish Government must acknowledge that the plan is now failing, and not only has its own goals not been realised, but women have paid the serious price for its long list of failures. Going forward, achieving the mission of improving women's health service support and outcomes requires the involvement of all sections of society, private individuals, public bodies and individuals dedicated to helping address women's health issues and inequalities. And just as importantly, women need to be heard. Healthcare in Scotland needs to see women's health issues as distinct, and as each unique aspect of each woman's life must be acknowledged and considered. And within my new role, I will work with colleagues from across the Chamber and in the Scottish Government so that women will finally receive the services so desperately needed to lead the fullest and healthiest of lives they can. My colleagues, Tess White and Brian Whittle, will highlight some other areas, such as menstruation and menopause, to maternity and neonatal issues. But I would urge the Scottish Government to work with us to avoid these failures in the future on behalf of women and girls across our country. I move the amendment in my name.
Thank you, Ms Wells. I now call on Carol Mochan to speak to and move Amendment 15382.2 around 10 minutes. Ms Mochan.
Thank you, Presiding Officer. Can I start by saying that I am so pleased that government time has been given to debating women's health today, and we will be supporting the government's motion tonight. I think if we have learned anything from this Women's Health Plan, it is that every target in the next Women's Health Plan must have attached to it a clear action plan and a pathway to deliver. Otherwise, it is just more words to women out there in our communities. And when our population desperately need action, I think it is incumbent on us to make sure that we have a delivery plan, and I am very pleased that the Government will be supporting our amendment at decision time tonight. Since the introduction of the Women's Health Plan, it has always been my intention, and indeed the intention of the Scottish Labour Party, to scrutinise it fairly with the genuine hope that it would be a success and that access to and quality of women's health services would improve right across the country. As the Minister indicated, securing a women's health champion was a significant step forward, supported by Scottish Labour, and it was a significant step forward in achieving some form of progress for women, and I welcome Professor Glacier's account of what the plan has achieved so far and what she hopes it will achieve in the future. Nonetheless, she and others continue to identify where there are problems and where we must strive to do better. Where we all agree is women's health must continue to be a priority if we are to have any hope of getting on top of the backlog of pain and misdiagnosis that so many women continue to suffer. All of us will have had meetings and phone calls with women unable to access diagnosis and treatment. And as others have mentioned, we have to give a particular mention to those with endometriosis. I am sure others will cover in their speeches today in the debating chamber, but women have suffered over many years. There has been an absolute void in service for this condition, and I do welcome the changes, but there is much more that needs to be addressed in the coming years. Presiding Officer, we are all pleased with the achievements, of course, of women's healthcare in this session of Parliament, in areas such as the introduction of the buffer zones to ensure women can access healthcare free of intimidation, to the rollout of the HPV vaccine as part of our fight to eradicate cervical cancer. And I'm desperately pleased to see the progress in these areas. I also want to mention, as the Minister brought it up, about the online platform so that real factual information is available to our young girls and women in Scotland. And as we go through our life cycle, that we can go back to that at the points that we need it. And Professor Glacier spoke to us at one of the meetings that the Minister pulled together cross-party. However, it is undoubtedly the case that in other areas progress has been far too slow and health inequalities have deepened and are very real for so many people in our most deprived communities. Members, we all have a responsibility in this place to acknowledge this and to scrutinise the government to ensure that the dial can finally be moved on this issue. We cannot have a debate like this in the Chamber without understanding life expectancy in our most deprived communities is falling and is far lower than those in our most affluent areas. And of course, we are all more aware of the issues around unhealthy life expectancy. Not only do our poorest, of course...
Tess White.
Thank you, Carol Mockham, for taking an intervention. Would the member agree that that there needs to be a separate roadmap for women and that the Women's Health Plan does need to be sex-specific? Thank you.
Carol Mochan.
Thank you to the member. Of course, yes. If I can come back to the point on life expectancy or unhealthy life expectancy, not only do our poorest neighbours die younger, they live life longer in a much poorer state of health. And this plays out for women in so many ways. They live in poor health and they care for others in poor health. And as so often the case, a heavy weight is often on the women in our population. In other areas that impact directly on women, maternity services, the situation of rural maternity services has been debated many times, but the reality is it is in members' time rather than government time. The government's inadequate response to this cannot be understated. Women in rural areas in particular, health is in real peril as they are transported often multiple miles at various stages of pregnancy and labour. It's a must that this is a priority for women's health in Scotland. Neonatal services, despite the genuine concerns of patients and staff throughout the country in communities such as Wishaw, the Scottish Government have continued with its policy of downgrading key neonatal units at the heart of our most deprived communities. This impact should be a concern to us all. Moreover, in cancer treatment waiting times, hysterectomy waiting times and reproductive health waiting times, women in Scotland are waiting far too long to receive the support they need. And often we hear of the lack of training opportunities that limit staff, so this limits any development in our services. Inequality, of course, is most pronounced when it comes to screening for cancer. As we know, women from the most deprived areas were less likely to attend breast screening, about 20% less likely, in fact. Rates of women who are up to date with their cervical cancer screening continues to fall, and I'm sure I do not need to remind the Government of the importance of improving these statistics. Many lives will be lost if we do not get on top of this. Again, we cannot debate this issue without some reference to the significant lower uptake of women from more deprived areas. And although I do not want to dwell too much on this, Presiding Officer, I can't contribute to this debate without mentioning the impact of strong cross-departmental working on women's health services and outcomes. It is absolutely imperative that the Government do better than this. I have raised this before in the Chamber. All government departments must see women's health inequalities as a priority, and there is no clear evidence currently that this is happening, or certainly not in the way that it should. In many ways, no matter how many iterations of the Women's Health Plan are brought before this Parliament, I would argue that a lack of willingness to acknowledge their own responsibility in this plays a big part in the suffering, or the ongoing suffering of so many women across Scotland. But I am very glad to hear the Minister acknowledge that today in the Chamber, and it's much welcome. The lack of urgency from this Government compounds this. I do not think it is unfair to say that the Scottish Government appear to have a belief that a policy paper ends a task, and the Scottish Government place very little importance on the delivery or the outcomes of the plans. And that is a significant point that we have to address together. Without serious reform and change of direction, which we have heard the First Minister is not committed to, this area of policy in terms of delivery will remain largely untouched, and the same challenges will be faced by women up and down the country if we debate this again in another 3 years. Therefore, although the Government will concentrate on the areas where it considers progress to have been made, as we did see in the opening speeches, I would urge serious caution on concentrating on this, and suggest that supporting our amendment, as you are, which is well supported from us, would show that you can be serious about setting out a route to deliver this. I do so, Presiding Officer, because, as discussed across all the parties speaking in the Chamber today, health inequalities impacting women remain stubbornly high. When publishing its plan initially, the Scottish Government referenced a British Heart Foundation report saying, in Scotland there are inequalities at every stage of a woman's medical journey. The question we must ask ourselves as we review the plan and look towards its next iteration is, has that really changed? The next Women's Health Plan must not only set out targets that it hopes to meet, but action plans to achieve these targets. And I certainly look forward to playing my part in making this happen. And I know that my party commit to doing that to ensure that we can change the outcomes and the health inequalities seen by women in Scotland today. Thank you.
Can we move the amendment?
And I move the amendment in my name.
Much obliged. Thank you, Ms Mochan. And I now call on Gillian Mackay, a generous 6 minutes. Ms Mackay.
Generous 6 minutes. Thank you, Deputy Presiding Officer. The Women's Health Plan launched in 2021 marked a significant commitment to addressing the distinct health needs of women across Scotland, aiming to close gaps in care, improving health outcomes and promote health equity. The very existence of the plan has brought much needed attention to issues that have historically been sidelined and significantly underfunded. It recognised that a dedicated approach to women's health is essential for the well-being of women and our communities at large. The plan also acknowledged the urgent need for societal and cultural shifts in attitudes towards women's health, along with the fact that much more was needed to be done in order to address long-standing health inequalities faced by women. It sets out a way to achieve these lasting changes, and I welcome the different updates we've received through the course of the plan. The final report, which is the topic of our debate today, sets out the very important progress made and raises the important areas in which work still needs to be done. Several commitments and the significant progress made towards them are to be celebrated. However, I am a bit embarrassed to say that in the progress section of this speech that I forgot to mention my own act in my notes. But I think that's my nature of wanting to move on and get the next thing done. But I do want to thank the Minister for her kind words about my Safe Access Zone Scotland Act, and I should also thank the Minister for Social Care for her support when she was previously in the Women's Health post, their teams, as well as all the campaigners and those with lived experience who gave evidence. Within the plan itself, no one will be surprised to hear that I welcome the Scottish Government's commitment to reviewing abortion laws, recognising the importance of a legal framework that reflects both current practice and the needs of patients and healthcare professionals. The Parliament has very rightly acknowledged abortion as a part of healthcare for those who need it. Law reform is not the only thing that needs to progress in terms of abortion care. Late-stage abortion and the staff and recruitment of staff who can carry it out also needs to be addressed. I hope that the law review will carefully examine the gaps and inadequacies in current legislation, assess the need for changes and consider how to bring about concrete change. However, this process must be urgent. There's no room for delay, and I hope we can see progress and a clear path being set out to achieve that before the end of the session. Scotland needs a responsive and timely approach to this issue. I feel the plan so far has also been a genuinely collaborative approach. The number of meetings we've had with ministers and with the Women's Health Champion, Professor Glazier, have been informative but have also felt like a genuine dialogue. And while I will move on to things I think we should be doing better or looking at, it is in the context of genuine collaboration and making progress for women in Scotland that I do so. And I am very pleased to hear that Professor Glazier has agreed to stay on as the Women's Health Champion.
Tess White.
Thank you for taking the intervention. I'd just like to ask you if you
through the chair, please, Ms White.
Sorry, I'd just like to ask the member if she sees that the work that we did as a committee on the buffer zones, that we benefited from working collaboratively. Thank you.
Gillian Mackay.
Absolutely. I think in the sphere of women's health, it very much does help us all if we can work collaboratively on that. And I hope that on the next stage of the abortion law review, for example, which obviously takes us into a slightly different space on abortion than on that pure access point, that we can have a similar level of conversation on that. I thought the conversation we had around safe access zones was quite grown up and quite even-tempered, and I hope that that can be taken forward in that next issue as well. Whilst recognising the strides which have been made between 2021 and 2024, I also want to shed some light on some of the critical areas that remain unaddressed or that require more attention. It is important to highlight issues such as access to fertility services, comprehensive support for endometriosis and systemic inequalities in health outcomes for women from minority and disadvantaged backgrounds that require attention. The report demonstrated that a stronger focus is also needed on addressing delays in diagnosis for conditions that uniquely or disproportionately affect women, and on ensuring equal access to healthcare services across urban and rural areas. There remain significant data gaps that act as a barrier to understanding and addressing women's health needs comprehensively. Conditions such as polycystic ovary syndrome, PCOS, premenstrual dysphoric disorder, endometriosis and other under-researched areas still suffer from a lack of robust data, which impedes progress in effective diagnosis and treatment. Several organisations directly involved in improving women's health have reached out, and I want to take the very short time I have left to highlight some of their very important observations and asks. ME Action Scotland highlights that ME and CFS is a complex chronic illness where 80% of patients are women. It's thought that there are approximately 58,000 cases in Scotland, but that remains an estimation because we continue to lack robust data. There are several reports of women being disbelieved and dismissed by doctors, and diagnosis can take years if it happens at all. And ME Action Scotland points to the importance and need for healthcare education to accurately quantify disease burden, along with the urgent need for data to be collated nationally in order to understand the full picture. One of the biggest thank yous, I believe, as mentioned in the motion, should rightly be to all those who have spoken to many of us about their health issues and often their very long journeys to diagnosis. For many, that journey has already happened or concluded, and they're often giving their experience, sometimes at their own cost, to make sure that no one else has to go through what they did. For some, this has been decades of campaigning, and we very rightly should be taking on their wealth of experience on this. We must continue to build on the momentum of the 2021 plan to increase awareness of women's health. This first phase of the plan has provided a solid foundation to build upon, but the rest of the work cannot be delayed. Women across Scotland are counting on us to continue advocating for them and their rights. Continued commitment to these unmet goals is crucial for fully realising the vision of the Women's Health Plan and delivering a Scotland where all women can achieve the care they need.
Thank you, Ms Mackay. I now call Alex Cole-Hamilton again. Similarly generous 6 minutes, Mr Cole-Hamilton.
Thank you very much indeed, Presiding Officer. It gives me pleasure to rise for the Liberal Democrats in what is a very vital debate. And I'm grateful to Jenny Minto for securing government time to bring this to the Chamber this afternoon. It's not a topic that we speak often about in this place, not least because women make up more than 50% of our society. They are vital to our economy. And yet many of the health issues we are talking about today are particularly gendered in nature. But, Presiding Officer, before I go further in my remarks to talk about the Scotland-specific picture, and indeed the report we debate and the plan we debate this afternoon, it would be remiss of me not to recognise the events of last week, and in particular what in America the election or re-election of Donald Trump to a second term means for the reproductive healthcare rights of women in America. That is a dark day with all three branches of government now stacked against those freedoms that we take for granted in this country, and we hold those women in our thoughts today. Because I am proud, Presiding Officer, that in this chamber not only resolved to safeguard those rights here in Scotland, but also committed to enhancing the quality, accessibility and range of healthcare services that are essential to women's autonomy, bodily autonomy and their well-being. I was proud very much to support... I'll take a...
Tess White.
Thank you for taking the intervention. Alex Cole-Hamilton references the US in relation to abortion, but will he also applaud the fact that even though Donald Trump is a controversial figure, he knows what a woman is? Thank you.
Alex Cole-Hamilton.
Well, I regret very much that Tess White wants to lower the tone of this, what has been a rather consensual debate so far. I would say that problem stems to her, and I'd ask her to reflect on those remarks. I want to re-foster, if I can, that atmosphere of consensus, Presiding Officer, by paying tribute to Gillian Mackay, who spoke very eloquently just before me, who spearheaded single-handedly the bill that she brought to Parliament around safe access zones, around clinics offering abortion reproductive services. And our commitment must remain steadfast so that every woman has the right to make informed choices about her health, supported by the very highest standards of care, free from abuse, intimidation and stigma, and dog whistle politics, like we heard from Tess White just there. As we've heard, the Women's Health Plan, introduced in 21, marked a step in the right direction. This plan rightly acknowledges that advancing women's health isn't just about reproductive rights. It's about treating women's health needs holistically and giving priority to issues that are often dismissed and stigmatised, particularly recognising the abundant health inequalities that exist in the Scotland today of 2024. That includes expanding access to menopause care, ensuring rapid support for postnatal contraception, and focusing on often overlooked conditions like cardiac disease, which affects women differently and yet has historically received far less attention and financing than heart disease in men. While I welcome the focus brought by the implementation of this plan, particularly the appointment of Professor Anna Glazier as the National Women's Health Champion, it is important that we can't rest on our laurels here. We must recognise the significant work that still needs to be done. For example, despite increasing awareness, many women suffering from endometriosis continue to endure years and years of severe pain before they're even given a proper diagnosis or pathway to treatment. These delays disrupt careers, they disrupt education, and they disrupt family life. And we know that endometriosis delays only compound that condition, may make it worse, increase the chances of it spreading and damaging multiple organs. We need to treat it with the same urgency that we offer similar conditions at the moment, and we are failing in that regard. Similarly, with coronary heart disease, which is a leading cause of death among women in Scotland, claiming the lives of more than 2,500 every single year, killing twice as many women as breast cancer. I'm pleased that the report has focused on this, and that the new specialist centre in NHS Forth Valley that's been proposed is especially welcome. But we need to go further. And we need to ensure that those women who are most at risk are given the advice and support that they need, and that are included in those experiencing early menopause or high blood pressure during pregnancy. We also need to improve access to menopause care more generally, particularly in rural areas. This is something of a postcode lottery, presiding officer, which remains inconsistent, with services stretched across the board. Menopause is a condition that will affect every woman in Scotland. It's not a surprise. It's something we can plan for. And yet I am struck by the lack of provision, or the patchy provision we have in so many parts of this country. I was visited just this week by a constituent who lives in our nation's capital, is going through menopause and is unable to access the basic advice and support that she needs. And, presiding officer, it goes without saying that the government has a duty to ensure equal access to treatment for all women, no matter where they live. We need to see each NHS board actively prioritising women's health within their areas. We know that women's health can be disproportionately impacted at times of financial strain. That is a gendered issue, which highlights the need to remain focused, even as the NHS budgets themselves are at full stretch. And for this plan to succeed, it needs to be backed fully by the government, and we need to ensure appropriate staffing, safe staffing, and regular updates on progress. Without these, it risks becoming just another set of promises. Liberal Democrats, presiding officer, remain focused on improving primary care, which is essential to women's health. It's essential to all of our health. But quick access to GPs, mental health specialists and services like physiotherapy can make all of the difference. We want world-class mental health services across Scotland, which could provide much-needed support for women facing postnatal depression or who are at risk of postpartum psychosis. We've come so far, but there's still a great distance to go when it comes to supporting perinatal mental health in Scotland. It's something I raised repeatedly in the last session, but I'm dismayed to see we have made very little progress on. In closing, presiding officer, I'd like to reflect on the cultural change that still needs to take place. Too often, women's health concerns are met with stigma or outright dismissal, or are subjected to dog whistle politics. We saw this clearly from the survivors of transvaginal mesh, who had to fight for years to have their pain recognised and treated. Health issues that disproportionately affect women deserve the same urgency, attention and seriousness as any other condition. They must be met with dignity and respect. I hope this plan that we debate today marks a renewed, invigorated commitment to seeing those changes through, so we continue to walk the path to a better, healthier future for women in Scotland. Thank you.
Thank you, Mr Cole-Hamilton. Before we move to the open debate, I note that a member that was looking to participate in the debate is not here through all of the opening speeches, for which I will need an explanation and probably an apology. But I call the next speaker, first in the open debate, Emma Roddick, to be followed by Tess White. Around 6 minutes. Ms Roddick.
Thank you, presiding officer. And I was glad to hear in the Minister's opening speech the progress which has been made on endometriosis, and in particular managing the pain that comes with the condition. I think there were some really good points made just there by Alex Cole-Hamilton around culture. And I do think there have been changes since the appointment of our Women's Health Champion. And I felt that change as a member of this Parliament and as someone who keenly listened to debate and discussion in this place on women's health issues before being elected to it. I can see that there is progress in the platform that these issues have, and the willingness of a wide group, not just the usual suspects who champion these issues regularly, to accept that there are problems and enter conversations about how to solve them. That bodes well for the overall aim to using the fact that Scotland has this role to precipitate wider societal and cultural change. And it's always welcome to see real leadership being taken in this place, cross-party, which can actually translate to changing minds and cultures outside. And I credit the Minister with the impact that her approach has made. While I'm a member of the same party, I've also enjoyed engagement with opposition colleagues regularly, with the Minister there on a wide range of issues relating to women's health. She's been open, understanding and willing to take on board expertise and knowledge which exists across the chamber. And that is certainly contributing to reaching the kind of cross-party consensus on women's health that Engender and others so far in the debate have called for. I would like to speak now about a few issues that will not be new to the Minister, having had conversations with her about them already. Firstly, mental health remains a significant women's health issue.
And what's difficult to see in statistics is the different experience which women with mental health issues face compared to others when accessing different services. Being a woman impacts the diagnosis that you will get if you have mental health issues. This is borne out in statistics, particularly when it comes to different mental health, cardiovascular or chronic pain conditions, where women and men often present with the same symptoms but are frequently given different diagnoses. Being a woman impacts the way that your other conditions will be treated if you have a mental health issue and chronic pain or fatigue. And I would bet that every MSP in this place has had a constituent raise evidence supporting that directly with them at some stage in the last 3 years. Being a woman also impacts the treatment that you receive. And there are times that that is justifiable because our needs may be different. But it's not acceptable that constituents of mine still feel they're being brushed aside or their symptoms minimised because they are female. And there are many chronic conditions which often come hand in hand with mental health issues. Now, living with chronic pain will affect your mood, often clinically. Mental health issues frequently are diagnosed in people with the likes of endometriosis, ME, MS, and many other chronic conditions. But we have to get better at drawing that distinction between clinical mental illness and reasonable reactions to difficult situations. Because almost every patient I speak to with a chronic illness and depression says that at some point they have been told something along the lines of course you're sad, anybody would be. Now, people with depression understand the difference between feeling sad and having depression. They are completely different in terms of quality of life, hopelessness and impact on your ability to function. One member of Glasgow Disability Alliance told colleagues in here a few weeks ago that they were told, "I would kill myself if I had your life." Now, that's the kind of stigma and dismissal that people face. It is a lot harder to get help for mental health issues if the people assessing you think that you should be feeling depressed. Now, given these cross-cutting issues between women's health and mental health, work on the approach to either needs to be done with awareness of the other. North Highland Women's Wellbeing Hub has done incredible work in sharing resources on many issues affecting women, which I'm sure the Minister is aware of, given her health colleague Marie and I share the area that the group covers. And at a meeting I had earlier this year, Kirstine showed me the leaflets and resources that the group has made up to support women who have been diagnosed with different conditions. Now, it's a shame that it felt quite wondrous to see endometriosis and menopause and POTS laid out clearly and imagine people in that moment that they're diagnosed receiving such helpful and clear information. But that is a massive step forward, and I hope that the government will be looking at the take-up of post-diagnosis support within NHS Highland that's come from the North Highland Women's Wellbeing Hub and consider how this kind of information can best be made available and standardised. It's also fantastic to hear the impact that having an islander in post has on sensible approaches, because accepting that we have to do things differently in different places does not mean that the end result has to be different. And the buddy system to ensure that island health providers can still access quality information is a great way to ensure that no matter where you are, you can access specialist advice. Finally, I just want to touch quickly on abortion care. Again, this is something that cuts across everything else that I've already spoken about. Pregnancy is more dangerous to some than others. Mental and physical health conditions combined with pregnancy can be life-threatening. So it's critical that we continue to strongly and frequently defend the right of Scots to access abortions in the face of attacks on these rights across the world. Nothing we've won is guaranteed, and we must keep recognising the necessity of quality and accessible abortion care. I am proud of the steps that this Parliament has taken to protect people accessing abortion services through the Abortion Services Act, which brought in safe access zones. But there is work to be done to ensure that there are services to access for everyone, for those who need it up to 24 weeks, which is currently the limit in Scotland in law, but not in practice. No matter where you live, you should not be forced to carry a pregnancy that you do not want to go through with. So I look forward to hearing updates on work to be carried out to ensure that is the reality. As do I look forward to seeing what comes of the next iteration of the plan overall. I'm hopeful and women's health is a topic it can often feel difficult to feel hopeful about. So I thank all those with lived experience who have rightly been at the centre of the work on the plan and the Government's motion today, and colleagues across the Chamber, including the Minister, who have put the work in on this. Thank you.
Thank you, Ms Ruddock. I now call Tess White to be followed by Kenneth Gibson in 6 minutes. Ms White.
Officer, as the first Women's Health Plan comes to an end, I do welcome the opportunity to take stock. And I want to thank Jenny Minto and her team for the cross-party working that she's done, and it has been constructive, so praise where praise is due. And I also want to thank Professor Anna Glazier, who's here today, for her leadership. I've enjoyed the lively conversations that we've had, and I valued Professor Glazier for her frankness, expertise and insights. 18 months and just 4 days a month was precious little time to deliver on the ambition of the Women's Health Plan, so I'm pleased Professor Glazier will remain in post. If only the SNP had appointed us sooner and had not left the plan in limbo for so long, but Minister Minto would probably expect me to say something like that. So, Presiding Officer, throughout the life cycle, from menstruation to menopause, a woman is adapting and adjusting to major changes in her body. She's also contending with a healthcare system that, as Caroline Criado Perez's Invisible Women describes, as systematically discriminating against women, leaving them chronically misunderstood, mistreated and misdiagnosed. Too often women do not feel heard. Too often their legitimate concerns are dismissed. We should not have to put up and shut up when it comes to pain. Healthcare cannot be one size fits all, but the male default bias has dominated the diagnosis and treatment of women for far too long. Healthcare, and people might want to dodge the bullet on this, and MSP colleagues, but healthcare must be sex-specific. And that's why women's health needs, they need to have a completely separate roadmap, a dedicated advocate, and a rigorous oversight in the long term. And that's why data in the NHS does matter, and why objective and immutable biological sex must be recorded on medical records. That, Presiding Officer, is why terms like chest feeders perpetrate the erasure of women in healthcare in the name of so-called inclusivity. The Scottish Government amendment today drills down into failings in women's healthcare that have occurred under this SNP government, because the reality is that under the SNP, women's healthcare has worsened. Waiting times for vital services like women's reproductive health, cardiac care and cancer screening and treatment are unacceptably high. Earlier this year, more than 500 women in NHS Grampian with suspected breast cancer had to travel more than 125 miles for diagnosis because the Health Board could not meet demand. The centralisation of maternity services in rural areas such as Stranraer and Murray is forcing prospective parents to travel for more than an hour and a half. And we're seeing an alarming postcode lottery in the provision of perinatal mental health services. And a simple test for preeclampsia is only just being rolled out by health boards, thanks to the proactive campaigning by the charity Action on Preeclampsia, years after NHS England. Presiding Officer, the SNP cannot reduce the gender health cap if healthcare in Scotland is inaccessible, but that is the stark reality for too many. After 2 years as the Shadow Minister for Women's Health, I recently took on the Equalities Brief and joined the Equalities, Human Rights and Social Justice Committee. It's clear from our pre-budget scrutiny meeting that budget decisions are made from a central belt perspective, without thinking about policy coherence on the bigger picture. And that's why the centralisation of NHS services is having a negative impact on women in rural communities. And with my own constituents having to travel from outlying Forfar to Dundee to have a simple IUD fitted. Gender and geographical inequalities are becoming further entrenched under the SNP's centralisation agenda. I've also been working with the North East Endo Warriors and recently met with Endometriosis UK on the distressingly long diagnosis time for endometriosis. There's growing awareness of this debilitating condition, but training and education aren't enough. I've been told the waiting list for diagnostic tools like a laparoscopy is 2 years minimum. That urgently needs to change. 2 years is just not good enough. As we look to the next iteration of the plan, I welcome Professor Glazier's commitment to prioritise pelvic floor rehabilitation. From relationships to participating in sport, the physical and emotional impact of pelvic organ prolapse on women is horrendous, absolutely horrendous. We need to look at countries like France, and the Minister has asked for examples, so I would like the Minister to look at countries like France, where women are automatically offered pelvic floor therapy as part of their postnatal care. Here in Scotland, women are told to do Kegel exercises and wear tenor underwear. It's an absolute disgrace. Presiding Officer, this isn't just about reducing the gender health gap. This is about how women experience the healthcare system and how that system supports them through their whole life cycle so that they can live happy, productive and pain-free lives. To achieve this, Scotland's NHS must be efficient, reliable and accessible for all women, always. And we have a long way to go. Thank you.
Thank you, Ms White. I now call Kenneth Gibson to be followed by Pam Duncan-Glancy. Mr Gibson.
Thank you, Presiding Officer. Over the years, I've often raised concerns about a range of women's health issues, from endometriosis and preeclampsia to cardiovascular conditions and breast cancer. These important issues of female health have long required further action, and I welcome the opportunity to discuss them today in the context of the Women's Health Plan. The plan is undoubtedly a step in the right direction, but I believe there are still significant gaps to be addressed. So today I'll focus on 4 key areas I feel should be central to ensuring women's health is properly prioritised and supported. Firstly, endometriosis, which a number of colleagues have already mentioned. 7 years ago, I led a parliamentary members' debate that ultimately resulted in significant progress, specifically and with the involvement and solid support of then Health Secretary Jean Freeman and Minister for Public Health and Sport Aileen Campbell, securing the opening of a 3rd accredited endometriosis unit in Glasgow to complement Edinburgh and Aberdeen. While the Women's Health Plan outlines positive aims through the endometriosis pathway, including improved access to specialist endometriosis centres and reducing diagnosis time, I believe these actions still fall far short of what's needed. In Scotland, it still takes an average of 8.5 years from the onset of symptoms to receive a diagnosis of endometriosis on average. This is simply not good enough to meet the needs of over 100,000 women who live with this debilitating condition. To truly prioritise women's health, we need more specialist treatment centres. In Ayrshire, for example, we must reduce the burden of long travel journeys and make it easier for families and support networks to be involved in care, expanding access to that care closer to home. The added stress of long journeys only serves to make treatment more difficult. This isn't just about improving healthcare access, it's about improving lives. My second point concerns cardiovascular disease, which remains a leading cause of death for women in Scotland, where 95,000 women currently live with coronary heart disease. This condition significantly impacts the quality of life and claims the lives of twice as many women as breast cancer. Thanks to British Heart Foundation research, sex-related differences in presentation and management of heart disease are now much better understood. Yet women continue to face significant challenges such as misdiagnosis, receiving fewer treatments and being underrepresented in clinical trials, all contributing in many cases to suboptimal care tailored to their needs. While we've seen a 14% reduction in coronary heart disease deaths over the past decade, recent trends show an increase, highlighting the need for sustained and focused action. Alarmingly, heart disease accounts for 1/4 of maternal deaths in the UK, with 77% of women who died not knowing they had a cardiac condition. This underlines a critical failure in our health service to identify, let alone effectively manage, heart disease in women. However, I'm encouraged by the progress made through the Women's Health Plan, which takes an important step forward in addressing these challenges. The plan's focus on increasing research funding and recognition of gender-specific health needs, particularly in cardiovascular care, is both welcome and much needed. We must build on momentum and continue to raise awareness of women's heart health across Scotland, ensuring that women receive vital heart health advice and support at every stage of their lives with health service interaction at every available opportunity. Recognition of the need for high blood pressure management, hypertension being a key risk factor for cardiovascular disease, responsible for around half of heart attacks and strokes, is vital. Clinicians, particularly obstetricians and midwives, must be equipped with the necessary knowledge and resources to offer advice and support to women at risk. By prioritising women's heart health, investing in early diagnosis and developing tailored treatments, we have a real opportunity to improve outcomes. Preeclampsia affects around 5,000 pregnancies in Scotland each year, yet it's noticeably absent from the Women's Health Plan, despite being the original 2021-24 plan. Maybe the Minister can tell us why. This life-threatening condition is serious and requires immediate attention, yet it remains overlooked in a strategy meant to address women's health needs. However, I'm pleased to note that NHS Lothian has taken a positive step forward by introducing targeted blood tests to help reduce risks for pregnant women. The placental growth factor-based PIGF test, which has been in use in NHS England since 2016, is a significant development in helping doctors diagnose preeclampsia. This test not only helps to reduce unnecessary hospital admissions, but, more importantly, ensures expectant mothers receive the care and support they need. Rolling out is taking place, but slower than it should be. Given the severity of this condition, manageable with early detection, I ask the Minister, as having asked her predecessors when PIGF testing will take place routinely across all the health boards in Scotland, ensuring every pregnant woman has access to this vital test. My own son died on his due date. My wife's liver ruptured, and she then spent 19 days in intensive care and high dependency because of a failure by midwives and doctors to diagnose preeclampsia. Post-event, women who suffered from preeclampsia are twice as likely to have heart attacks and strokes as women who didn't. Yet there appears to be no follow-up whatsoever, a matter I have previously raised with the Minister. Instead, there is a suggestion that such women, lay members of the public, self-monitor their blood pressure for the rest of their lives. Even Women's Health champion Professor Anna Glaser in the gallery today calls this in the health plan a rather tall order. Finally, I turn to primary biliary cholangitis, PBC, a chronic liver disease that many women across Scotland are living with. Following a roundtable meeting at the Scottish Parliament, which Gillian Mackay kindly chaired, a recent report highlighted significant disparities in the experiences of women living with liver conditions. The findings reveal that these vary widely depending on geography, with many reporting feelings of stigma associated with their liver condition, despite it not being caused by any action of their own, such as alcohol consumption. The report also recommends a wider rollout of the Intelligent Liver Function test, currently used routinely to assess liver health in Tayside and Fife. Dundee University research shows the test increases the diagnosis of liver disease by 43%, allowing earlier, more effective treatment. Expanding access to this test would improve early diagnosis and care for women living with liver conditions across Scotland. Scottish ministers should also actively raise awareness of PBC. Presiding Officer, the Women's Health Plan provides us with a clear path forward, but much remains to be done. By continuing to build on this progress, we can ensure that women across Scotland receive the care and support they deserve when they need it most. Thank you.
Thank you, Mr Gibson. I now call Pam Duncan-Glancy to be followed by Claire Adamson. Ms Duncan-Glancy.
Thank you, Deputy Presiding Officer, and I want to thank the Government for bringing forward this debate on such an important issue today. While I welcome that some progress has been made on the Women's Health Plan, as the Minister has set out and others, and the Government is looking forward to the next steps, I fear that many women are still unable to access appropriate healthcare as and when they need to. Women in Glasgow, especially from more deprived areas in the region, are less likely to attend breast screening or cervical screening than women elsewhere on mainland Scotland. Until very recently, women in Glasgow experienced harassment when attending for abortion, and I'd acknowledge the success of Gillian Mackay and Back Off Scotland's work on safe access zones in this regard. But still, there remain barriers to access abortions in Glasgow, where access to information on what's available still prevents timely access when needed. And as with elsewhere, women in Glasgow still wait far too long for diagnosis of endometriosis or polycystic ovary syndrome, leaving many living in significant pain. Presiding Officer, the situation in Glasgow for women must be turned around, and we need a different direction on this from this government to do that. In addition, though, we need a different direction for specific groups of women too, because, as Engender and others have highlighted today, minoritised and marginalised women's health experiences are still not fully recognised or addressed. And I'd like to use the rest of my contribution today to speak of the need for that. In fact, women continue to face stubborn inequalities in how they experience healthcare. Like Engender and others point out, and I and my party are, we're all concerned by the slow progress on this. Years on from the publication of the plan, 65% of respondents to research by Young Women Scotland stated that being disabled is still associated with a lack of healthcare. They cite various reasons for this, including that there is a lack of understanding of the need to treat multiple conditions holistically, as well as, in some cases, bias and discrimination. The Women's Health Plan highlighted this issue, and specifically a research report by Engender, published in 2018, which described how disabled women in Scotland experience specific barriers when accessing a range of health services, including a lack of accessible facilities, specialist equipment and accessible information. The plan acknowledges the importance of considering how sex, gender and disability intersect, and the specific needs and experiences of marginalised disabled women. It concluded that it was important for healthcare professionals and health policy makers to recognise that a failure to take an intersectional approach can lead to further discrimination or disadvantage. Presiding Officer, I'm concerned that many disabled women still face the same problems identified in that 2018 report today. It has been brought to my attention that access facilities are not being prioritised as part of redevelopments of new health centres. In fact, they appear to be deemed so unimportant that they are the first thing to be cut as health and social care partnerships are looking to reduce costs. The promised changing places toilets, for example, and hoists within GP surgeries were not installed in new healthcare centres in my region. I would think that development of new buildings was the perfect opportunity to ensure access for disabled women is assured, rather than considered later. But this opportunity is missed. There also seems to be a lack of awareness amongst healthcare professionals where specialist equipment is in place. For example, in one of the health centres in the Glasgow region, a hoist was available, but none of the GP practices within the building were aware of it. A report by Glasgow Disability Alliance, published in 2022, found that the global pandemic has made it even harder for disabled women in Scotland to access women's healthcare, because many have more complex needs than can be met through their GP surgery. It also found that some disabled women felt unable to seek healthcare due to a mix of reasons, but including guilt associated with the need for additional things from an overstretched system. Disabled women should not feel guilty for having more complex needs, which, I should not have to say this, they didn't ask for. The report found lengthy delays in accessing health services and that they have significant health and life implications, including loss of function and mobility, missing potential problems or conditions and opportunities for preventative interventions. And the report then therefore recommended that disabled women have the option to be accompanied at medical appointments, including on admission to hospital for communications and/or support. It also recommended that disabled women have access to the equipment they require. Given access to healthcare is a fundamental human right, it's extremely concerning that this was still a recommendation in 2022 and, as demonstrated by the examples outlined, it still applies today. Disabled women are being failed and lives are being lost as a result. I was made aware of a situation where one of my constituents was sadly unable to receive a smear test due to the fact no hoist was available when she attended her appointment. Heartbreakingly, my constituent later lost her life due to a rare female cancer. If the correct equipment had been available, I am cognisant of the fact that this outcome could have been different. My thoughts are with my constituent and her family, who have been failed by the current system. Presiding Officer, something must change. The Women's Health Plan outlined government plans to launch a wider programme of work to specifically target inequalities across all screening programmes. But 3 years on from its publication, not enough progress has been made. In the Scottish Labour 2024 manifesto, we recognised this and said that despite the publication of the plan, women continue to face inequalities. And we committed to ensuring greater uptake and ease of access to screening services, including the rollout of cervical screening self-sampling. We recognise that local GP surgery is the first port of call when a health problem starts, and we're committed to ensuring they provide a range of services and to growing multidisciplinary teams, which are crucial. These are some of the ways that could ensure disabled women would no longer face barriers to basic health care. And so the next plan must be clearer in setting out solutions for improving all women's health care, including unambiguous timescales for delivering the required change. And in the words of Glasgow Disability Alliance's report, our society must be one in which disabled women participate, have their voices heard on a full and equal basis in all aspects of our lives, communities and wider society, with choices equal to others and our human rights upheld. Thank you, Presiding Officer.
Thank you, Ms Duncan-Clancy. And I now call Claire Adamson to be followed by Audrey Nicholl. Ms Adamson.
Thank you very much, Presiding Officer. And I'm very pleased to be able to contribute this afternoon to what has been a very informative and excellent debate. And I maybe begin by following on from Pam Duncan-Clancy and her very personal, thoughtful contribution around the access for disabled women, and mention also that we haven't maybe examined some of the cultural barriers from our Black and ethnic minority groups so far this afternoon. We know that the accessing mental health services can be a particularly challenging issue in some cultures, and also the birth mortality rates for Black women has been well documented both in the UK and abroad. And I think a better understanding of all the cultural barriers for women seeking help and getting the support that they need to be examined in further detail. I'd also like to thank Annie Wells for bringing out the poverty-related aspect to some of the challenges that we have too, particularly representing an area with, like my own, with historic low life expectancy for both men and women. And also again to thank my colleague Kenny Gibson for his very personal reflection on his own experience, not for the first time in this chamber. It is very important that we all hear these lived experiences of women and of partners, and of the whole family impact of what can happen in these very difficult circumstances. I'm glad that we are joined today in the gallery by Professor Anne Glazier, who has been mentioned on many occasions this afternoon for her lead in this area. And I think it's worth remembering that this was the first women's health plan in the world to be published by a government, the first attempt to have an examination of the inequity that women experience in this, and how much we now understand more risks, many of which have been mentioned this afternoon. Alex Gold-Hamilton mentioned about the heart issues, risk from endometriosis, polycystic ovarian syndrome, mental health associated with menopause and postnatal depression. And Alex also mentioned psychosis, postpartum psychosis, which is, can be devastating for the women and the families that are affected by that. And really, this is a pathway from puberty through to elderly age, and we now know some of the other issues that may face women in beyond menopause in terms of osteoporosis and other areas. And of course, our screening, so important, again mentioned this afternoon, but breast screening, ovarian screening, and also the access to HPV vaccines, which can now do much to prevent cervical cancer. And it's interesting that we're having these. They're commonplace in the media now. They're commonplace in debates in this chamber. So I thought I'd look back and see, when did we first start talking about this, given that this first report was from 2021 to 2024. And in the first session of the Parliament from 1999 to 2003, there were 4 mentions of menopause. 3 of those were mentions to the ancillary main issues being discussed. One of them was in a mention to relation to mental health, Men's Health Week. And it's interesting that very little changed over the few years after that. The second session, menopause, was recorded in the official report a couple of times. Between December 2003 and 2013, there were only 7 entries in the official report that mention it, including in relation to other areas, again, not focusing on women's particular health issues. And in 2017, we saw the first real mentions of menopause as a cause for women being dismissed for other health areas, And a petition on thyroid and adrenal issues came forward when the issue of incontinence was mentioned, and menopause being something that causes women's health problems to be dismissed, as has been mentioned already. In sessions 1 to 4 of the Parliament, the word tampon was mentioned once, and of course we now have that groundbreaking period bill that was brought to the Parliament, where period products are free to those in need in Scotland, and another first for Scotland. And in May 1999 to 2016, menstruation was mentioned 5 times, 3 times in the context of female genital mutilation, but for something that most women experience around once a month, and millions of us go through it, it seems incredible that we weren't discussing women's health issues long before then. And I'm really pleased to see that we've now moved on from that. And undoubtedly, we do have a long way to go to redress women's health inequity. But I think it's worth recognising how far we've come. And the debate in hand today and the contributions show that we are taking this seriously. We understand the challenges. We understand there's a lot more to do. But I'm delighted that we are on that pathway now of the Women's Health Plan being there. And we look forward to hearing how the Government intends to implement the work that has already been done under the stewardship and leadership that we have with us today. So thank you very much, Presiding Officer.
Thank you, Ms Adamson. And I now call Audrey Nicholl. Ms Nicholl.
Thank you, Presiding Officer. And like colleagues in the Chamber, I'm very pleased we're taking time to debate the subject of women's health this afternoon. It's certainly an issue that appears in my constituency, Postbag, on a regular basis, and which has raised a number of important points in the course of this debate. The motion doesn't take away from the fact that there is still much work to be done to develop women's health services further, but this is a very important first step towards addressing some of the inequalities impacting half the population of Scotland. And nowhere are the long-standing health inequalities impacting women more evident in the justice space, and I'll focus on that a little later in my contribution. I'm enormously proud of a health system that has, in the last few months, seen me receive my flu jab, COVID jab, my cervical screening, free eye test, well woman check, my mammogram, asthma review, audiology referral, and a free prescription for antibiotics. These are all effective and important preventative approaches that are part of the wider programme of activity to keep women in good health and that intersect with the priority areas in the Women's Health Plan, including menopause, menstrual health, pregnancy, contraception and, of course, endometriosis. A few months ago, I had the pleasure of visiting the Women's Health Services team at Aberdeen Royal Infirmary, where I heard about the significant progress being made to develop health services for women, including endometriosis and breast screening. And I heard about the fantastic progress being made by NHS Grampian, alongside the University of Aberdeen and Chiron Medical Technologies, to develop MIA, or Mammography Intelligent Assessment, a promising AI technology that can identify minuscule traces of breast cancer that can be missed through conventional practice. And as one of the team acknowledged, even doctors are human. They get tired. They've been up all night with a crying baby. They're full of the cold. So I have a number of constituents who are interested in seeing this model extended further to that of a hub. And I'm grateful to the Minister for her previous engagement with me on this issue with specific regard to menopause services for women. And I'd welcome any further update that she can provide on progress around hub provision in the North East. And I was very interested to hear Emma Roddick's reference to the Highland hub earlier. One issue that has been raised with me is that of urinary tract infection, and while the Women's Health Plan does make reference to recurring UTI, it doesn't reference chronic UTI, which we know has a significant impact on women who experience it. Now, we're all probably typically a member of the worried well population in society, thankfully more well than worried, but I welcome that the plan acknowledges what is commonly known as the inverse care law, or how women who most need healthcare are often least likely to access it. And I commend the work that's been done recently by the University of Glasgow and the University of Edinburgh looking at how to tackle inverse care law in general practice in Scotland. And this brings me on to my final point, which is the challenge that women in the justice system face in terms of their health and well-being. Now, the Women's Justice Panel report, The Care for Gendered and Intersectional Approaches to Justice, outlines how women typically enter the justice system in different ways from men and for different reasons. Scotland has a relatively high incarceration rate for women compared to other countries, including in Europe, and it is commonly accepted that the health needs of women in prison are often not met due to a complex layer of factors, including domestic abuse, addiction, trauma and compromised mental health. And for women who have family members in prison, the practical harms associated with reduced household income, stigma, the loss of practical and emotional support that they previously relied on from the family member, even the cost to travel to prison visits, can take a significant toll on their health and well-being, further driving health inequalities that we know disproportionately impact women caught up in the justice system. And to a great extent, women serve a hidden sentence of their own in this regard. So, of course, the priorities set out in the plan apply equally to women in prison. They don't stop having periods, the menopause, or even being pregnant. So humanising healthcare in this space will help women be well and more resilient for when they leave prison. And across Scotland, the establishment of trauma-informed community custody units for women, such as the Bella Centre and the Lilius Centre, is leading the way in preparing women to leave prison, and it provides a real opportunity to insert even better healthcare services at that crucial release point. So, to conclude, Presiding Officer, I would be very interested to hear any update that the Minister can provide on what opportunities might exist to insert some more focus on women's health in prisons into the next stage of the Women's Health Plan. And I very much look forward to following and even contributing to the plan's future development. Thank you.
Thank you, Ms Nicholl. And we will now move to closing speeches. And I call on Gillian Mackay to close on behalf of the Scottish Greens, around 6 minutes. Thank you.
Thanks, Deputy Presiding Officer. This debate today has been very interesting, and I wanted to start by reflecting on some of the contributions that we've had. The Minister, in her opening, laid out how important it is to look after the health of women because it's looking after the health of the nation. I think it is important in this debate that we point to the other factors out with the Minister's portfolio and actually the Women's Health Plan that also have an effect on the health of women. The Minister mentioned unpaid carers, and I think they're the perfect example of how many other portfolios can drive health inequalities or otherwise. The rate of carers allowance, access to carer support plans, being able to get respite to attend appointments, all have an impact on the health of those carers. Another area that the Minister mentioned is pregnancy and baby loss. Several friends have pointed out to me how they find it interesting during their pregnancies that almost every symptom they asked healthcare providers about was normal, even when those were complete opposites. For example, whether they had a higher than normal level of appetite and were concerned about that, or whether they had no appetite at all when they believed they should have. Both were totally normal. And I think information and clear explanations are needed in these areas. Many women have been told to just battle on with debilitating symptoms in pregnancy that we wouldn't expect anyone else to do, purely because there's a stigma on how early it's okay to tell other people about their pregnancy. I know some friends who, after a loss, regretted not telling family earlier. They had a bereavement without the celebration of their happy news, and I think we do need to assess whether some of these norms are making losses harder. And I do commend Kenny Gibson for sharing his personal experience in this regard. We need to ensure employers are aware of all the ways in which they can support pregnant women, and that women are supported to reveal their pregnancies whenever they are ready to, not when tradition dictates that it's okay, especially if they feel they need that support. I'm very glad that the Baby Loss Memorial Book is open to those who have historically had a miscarriage. And I'm sure many of us have had meetings with those who have historically lost a pregnancy and have heard of the sense of validation of their experience. Alex Cole-Hamilton, Claire Adamson and others have mentioned postpartum depression and postpartum psychosis, among other issues, which are hugely important to address. The Health, Social Care and Sport Committee have undertaken work on perinatal mental health, and I think this is a piece of work that would certainly be worth repeating in a future session. Emma Roddick mentioned chronic pain in her speech and the lack of being believed about a multitude of symptoms, but particularly pain is devastating for many. Why the default is not just to believe that it is something women are experiencing and then try to find out what is manifesting that pain, rather than not believing that pain exists in the first place, boggles my mind. Kenny Gibson very kindly mentioned my chairing of the PBC event last week. Primary biliary cholangitis, which is not easy to say at this point on a Tuesday afternoon, is an autoimmune liver disease affecting predominantly women, around 90% of all cases. The symptoms of PBC, such as itch and fatigue, can have a profound impact on a person's quality of life and mental well-being. Those affected often feel misunderstood and sometimes stigmatised because, unlike many other liver conditions, PBC is not the result of alcohol or drug consumption. Instead, risk factors may be gender, older age, genetics and where a person lives. As I said in my opening speech, I was pretty in awe of these women, sharing very raw experiences of how this has and continues to affect their lives, how it's affected their families, their experience of transplant and their own mortality. They spoke with a passion about what they want to see and how they see their own care, and I'd encourage others to engage with the groups that were represented there. Kenny Gibson and others also mentioned cardiovascular health. We know that symptoms often for a heart attack can manifest differently in women. Many of us try to raise awareness of these symptoms, but where they're not accurately being defined in women is potentially a big problem. That is why I won't stop going on about data, and why I was really pleased to see a review of the data landscape published alongside the Women's Health Plan report. Some of the data we need to see is not just more things that the government needs to collate, but actually funding specific academic work to make sure that we understand many of these symptoms and causes better. There are other issues that organisations have asked to be raised that I didn't have time to earlier that I will try to race through just now. Breast cancer now have underscored the need for a stronger emphasis to be placed on the life course approach when women interact with the healthcare system. More should be done to provide information to women on how to check their breasts, be reminded of when they'll be invited for breast screening and provided with the tools to make an informed choice to attend. They also point to the fact that the Scottish Government's 2021 major review of breast screening recommended the consideration of bringing high-risk screening within the remit of the National Screening Programme. However, the project is outside the board's scope, requiring a specific business case and funding. As a result, they advocate for the next iteration of the Women's Health Plan for Scotland to provide an opportunity to fulfil the review's recommendations and conduct a larger piece of work to fully assess the potential advantages, feasibility, benefit and cost of integrating the high-risk surveillance with the National Screening Programme. Engender has highlighted the need for more details to be provided on how COVID-19 has impacted women's health outcomes and affected the implementation of the Women's Health Plan, including whether this has limited the scale of change delivered. They also renew their calls for future work on women's health to focus on an intersectional approach which recognises and addresses minorities and marginalised women's health experiences. I look forward to working with and learning from Professor Anna Glazier in the next iteration of the plan, as well as working with the Minister and the rest of Government to achieve the aims that we all dearly hold. And I do hope that we can continue in the largely constructive tone that we've had today.
Thank you, Ms Mackay. And I now call on Jackie Bailey to close on behalf of Scottish Labour. Around 9 minutes, please.
Thank you very much, Presiding Officer. I welcome this debate. I welcomed the plan, but I do have to say that progress has been slow. The report was launched 3 years ago, yet we haven't shifted the dial on the inequality that continues to plague women's health. I know it won't happen overnight, but I do think we need to make more progress. Let me strike a note of consensus and agree with the Minister's comments that to prioritise women's health is to prioritise the health of Scotland. That's why this agenda is so important. But I fear that women's health is too often treated like an afterthought. And whilst the Government took more than a year to appoint the Women's Health Champion, I very much welcome the work undertaken by Professor Anna Glazier. She's certainly been very hands-on in her approach and has a hugely important role in making change. But it needs leadership and resourcing from the Scottish Government. And we are very welcoming of progress on issues like HIV and STI self-sampling. But what about cervical self-sampling? Promised in the first year of the plan, but 3 years on, and it appears that only Dumfries and Galloway have a pilot. And in the report published last week, there is no mention of cervical self-sampling. So when the health plan was published, colposcopy waiting times were so bad that women with a suspicion of cancer were waiting more than 300 days to be seen. It was a real postcode lottery. If you lived in Lanarkshire, then it was fine. You were seen timeously. But if you lived in NHS Greater Glasgow and Clyde, it simply was not good enough, waiting up to a year. Now, I understand that matters have improved, and that is welcome, but there is still a long way to go to ensure consistency across Scotland. I welcome the progress with the HPV vaccine. My daughter was, in fact, in the first cohort of young women to receive it. And that's great. But the plan also promised to address health inequalities in cancer screening more widely. Yet Public Health Scotland statistics show a stark inequality in the level of uptake for breast cancer screening mentioned by others between women from the most deprived and the least deprived backgrounds. There is a shocking 18.8% point disparity between the richest and poorest attending their routine breast cancer screenings. And Cancer Research UK previously estimated that there are approximately 4,900 extra cancer cases each year in Scotland attributable to deprivation. So we need to make more progress there, because thousands of women overlooked and put in danger due to their socio-economic position. And that's a shocking indictment on any government. Annie Wells was right to talk about waiting times for endometriosis. And I recognise the positive steps taken and welcome the new pathway and the research and the specialist centre in Aberdeen. But women are still waiting as much as 9 years for diagnosis and treatment. And I cannot begin to imagine the pain and suffering that they experience. And I would simply note, if this was a condition affecting men, action would have been taken before now. I don't underestimate the scale of the challenge. Women continue to have the highest levels of poor mental health. More women suffer from a limiting long-term condition, 45% of women compared to 29% of men. Women are more than twice as likely to die from heart disease as breast cancer, whilst also being more likely to receive the wrong diagnosis and receive half as many heart treatments as men. Sexual health clinics in part of my constituency withdrawn and centralised because of a failure to plan for the retirement of a clinician. You really couldn't make this up. In all these cases, we need to do better. Yesterday, I met with several very impressive women. These were women that, because they were pregnant but not married, were subject to forced adoption. Either as mothers who had to give up their babies, or indeed the babies now grown into adults. And it was a very emotional meeting. And I, for one, absolutely welcomed the public apology from the former First Minister, Nicola Sturgeon, given to them for what happened. But there has been no action since, not even any provision of trauma-informed counselling. Now, saying sorry, I know, is hard to do, so I do not in any way diminish the impact of the apology. But to do little in the way of follow-up is shaming to us all. I don't want to disrupt the cosy consensus, but I have to express my disappointment, because the SNP cut £10 million from women's services and reduced funding for transvaginal mesh removal. The last people who should be paying for the SNP's mismanagement are women who have endured years of crippling agony. But the cuts don't stop there. There will also be cuts of almost £3 million to early years care, to breastfeeding and to young patient family funds. The very same funds that women have been told to rely on should they give birth to the most premature babies. Forced to travel over 3 hours for treatment under the SNP's plan to remove specialist neonatal services from Wishaw and other units across Scotland. And that's against the views of expert clinicians and the families across Lanarkshire. Now, my mother always used to say to me, follow the money. If something is important, you put resources behind it. In the SNP's case, they have cut funding, and that really tells you all you need to know. The Scottish Government will receive the largest block grant from the Labour Government in the history of devolution. Every single penny of health must be spent on health, and women's health in particular. And let me offer an early win for the SNP to consider. One of the biggest problems with menopause services is the waiting times for referrals to specialist clinics, largely down to requiring multiple GP appointments before diagnosis of symptoms. 90% of menopause cases can be dealt with in primary care, and community pharmacy has a key role to play. So I am genuinely disappointed to see that this is a long-term goal. Yet there is a menopause service on a digital community pharmacy platform just now, which would deliver a better integrated service for women within 6 to 12 months, much more cost-effective for the NHS. So I don't have any idea why the SNP are not interested. Let me turn to comments from Engender, because they very helpfully provided a briefing, and I want to pick up 2 issues that they raised. Firstly, we should understand what funding and investment has been made to help in the delivery of the plan and what accountability measures and monitoring are in place, and that is the essence of our amendment, and I welcome the fact that the Government will accept it. The second issue is the new Scottish Institute for Women's Health, promised in the plan but not delivered, a body that can drive change to improve women's health outcomes, and I ask the Minister to consider this together with Kenny Gibson's suggestions of local clinical provision for women. I think both of those are important. And whilst the NHS and social care in Scotland remain in crisis, women are overwhelmingly paying the price. We know that 1 in 6 Scots are on NHS waiting lists. Long waits at A&E put lives at risk, and delayed discharge is at a record high. So we need to do better. And I agree with Professor Glazier that we must make the health of women central to every area of healthcare. But this will only be achieved with the proper levels of planning and funding. The Scottish Government should also commit to addressing the large data gaps in reproductive health, in endometriosis, menopause and contraception. Now, there is no silver bullet for underdoing years of inequalities in women's health, but the pace of change needs to be picked up. Carol Mockin is right. We need more than words, we need delivery. Policy papers do not mark the end of the task. We need reform and we need to get on with the job. And I think we can all agree, Presiding Officer, that the women of Scotland deserve better.
Thank you, Ms Bailey. And before I call Brian Whittle, I just would advise members that we do have a wee bit of time in hand to take us to decision time, so I can be extremely generous, Mr Whittle, who will now be closing on behalf of the Scottish Conservatives. Mr Whittle.
Oh, I'm so very grateful, Deputy Presiding Officer. Can I thank you, Presiding Officer? And first of all, I'm going to declare an interest in that I have a daughter who is a midwife. I think this has been a really excellent debate with very much agreement across the Chamber. After all, I think it's obvious that we all want to see faster progress towards parity for women's health. And I was very struck when with the World Health Organisation's statement that health is a state of complete mental and social well-being and not merely the absence of disease or infirmity. But that's against a backdrop in Scotland where we have a significant poor health issues. And despite the claim from the SNP that they spend more per head of population on health than the rest of the UK, we have much poorer outcomes. And that is what matters. Scotland is the unhealthiest country in Europe. You get the highest obesity numbers, highest drug and alcohol deaths, comparatively low life expectancy, and it's falling, and so on. This, of course, impacts on women's health, which already suffers a significant inequality. I know Tess White made a really powerful speech in which I paraphrased, but what she said was, we know less about how best to treat diseases in women. I was very grateful to Alex Cole-Hamilton for raising the fight of the transvaginal mesh woman. If there's anything that should highlight the inequalities in women's health, it is that. My overwhelming memory of the last session in Parliament was sitting in Petitions Committee, questioning the CMO and the Cabinet Secretary, where behind them sat some 40 or 50 women in wheelchairs in unimaginable pain, searching for a solution. And if they ever, as I said, if you ever want to know or highlight inequalities in women, that's where we should start. ME affects 4 times as many women than men, and it's only fairly recently we've started to get doctors to actually recognise the condition. As many people have said in the chamber, coronary heart disease kills twice as many women as breast cancer and kills more women prematurely. And we know that a third of eligible women haven't had a smear test in 21-22, and that women from a deprived area are significantly more at risk from missing a smear test than those from the most affluent areas. And it's the same for breast cancer. I think that's a theme that's been a thread that's gone right through today's debate. So the Women's Plan, if it is to be successful, must consider how the message reaches out to those women and, crucially, how we ensure easier access to these services. It cannot be right, as Tess White highlighted, that women are having to travel up to 125 miles to access screening as they do it in NHS Grampian because the local services cannot cope. So, Deputy Presiding Officer, we have a service that is underutilised, yet cannot cope with the numbers trying to access the service. Annie Wells quite rightly highlights that the continuing shameful alcohol figures has a significant impact on breast cancer numbers, as well as other breast cancers. And as Carol Mohan and Annie Wells highlighted, as others did, it's taking more than 8 years on average to get an endometriosis diagnosis for a condition that will affect 1 in 10 women. That's not progressive women's health in my book. Now, Deputy Presiding Officer, given its impact on physical and mental health, it would be remiss of me not to mention the disparity in numbers for women participating in sport and physical activity compared to men. Early opportunities to get active are more difficult for girls than boys, and there is still a stigma that exists around girls playing sport, especially around the age of menstruation. Much of this has to do with perception and access to safe, adequate changing and shower facilities, and I'm afraid that hasn't improved much in recent times, despite it being highlighted consistently. Society is not caught up, as is evident from the back pages of any newspaper, where women seem to be an afterthought at best. And I note at the weekend, Deputy Presiding Officer, that there were 2 netball internationals played, and I didn't see any coverage in the media. And you have to be able to see it to believe you can do it. And the only reason I know this, and I'm going to just mention this, is my daughter happens to be an ex-netball international who mentioned it to me. So women's football, cricket, golf and rugby are moving forward globally, but I think it's time we caught up in Scotland. Although I would note that in my own sport of athletics has seen Scottish women more prominent, which is good to see them buck the trend, and it shows it can be done. So participation must be tackled and developed to impact general overall health benefit that is both physical and mental. Presiding Officer, before entering this Parliament, I worked in a healthcare technology company, developing communication and collaboration platforms for healthcare. One of the targets was to allow a global reach in new medical trials, taking into account the effectiveness of those drugs across different ethnic groups. But the uptake globally was actually in the region of 80% male. So to back Tess White's call for women's specific treatment plan, the big issue is around the efficacy of medicines for women. It is a fact that most medicines, when at the testing stage, are mostly tested on men, and then the dosage is extrapolated for those results to define dosage for and effectiveness for women. However, not only is this an inexact science in terms of that dosage, it also does not necessarily take into account the different biology in women, things like bone density and muscle mass and fat content and menstruation. Mirroring society, whether it male-female split or in ethnicity variations, must be a significant goal for medicines if we are to tackle women's health inequalities. And I would appreciate it if the Minister could suggest how the Scottish Government can take steps to address what is a long-standing issue. Now, I have to say, I listened to the Minister discuss the neonatal services at Wishaw, and Carol Monaghan took that further into rural neonatal units. And I listened to what Jackie Bailey had to say, and I think Jackie Bailey would agree to me. We obviously spoke to a different cohort of constituents, a different cohort of healthcare professionals, because it seems to me that the downgrading of the services at that maternity unit in Wishaw General Hospital is creating a specialist unit in Glasgow to the detriment of Lanarkshire mothers, as well as now not using the significant specialist skills that have been developed at Wishaw, is really based more on not so much based on delivery of healthcare. It seems to me it's more an administrative decision, given the way in which this has been discussed many times in this chamber, and it's wrong to develop and deliver women's health care in this manner. So, Deputy Presiding Officer, as I said, this has been a very important debate, shining a light on women's health and the inequalities that exist. And I know that across this chamber there is the desire to improve and impact the health of women and girls. However, we must accept that we are a long way from parity in that healthcare. This debate is very welcome, but change will only come about if the Scottish Government listen to members from across the chamber and act on those suggestions and develop those plans. Better outcomes, after all, is what we all want. Deputy Presiding Officer.
Thank you, Mr Whittle. And I now invite Minister Jenny Minto to close on behalf of the Scottish Government. And I would say to the Minister that we still have some time in hand. And if the Minister could take us to as close to decision time as possible, that would be much appreciated. Minister.
Thank you, Presiding Officer. This afternoon's debate has once again highlighted how vitally important it is to prioritise the health of women and girls. In listening to the contributions from members, I am both greatly encouraged by the progress we've made, but I'm also under no illusion that a lot of work remains to be done. The plan recognised the need for a societal and cultural shift in attitudes towards women's health to tackle the inequalities that women have faced for generations, as Carol Mochan and Gillian Mackay both referenced. And this doesn't happen overnight. And it shouldn't, because we need to ensure we see lasting change. It's clear that there are specific areas where renewed and targeted focus is required, long waiting times for gynaecology being a clear example. This first phase of the Women's Health Plan has provided a solid foundation for us to build upon, but we're not finished. More work does need to be done to ensure that women and girls in Scotland are listened to, informed and supported to enjoy the best possible health through their lives. And I and the Scottish Government remain committed to this ambition. I would really like to focus on a few points that have been made. When I came into this role, and I know Ms Todd as well, we both felt that it's important to understand the views from people across the chamber, and we have been very open in the way that we have connected, and I very much appreciated the comments from other members appreciating that. And I think the benefit that we all have of meeting half-yearly with Professor Glazier and having that space where we can talk about concerns and find responses has been very worthwhile. A number of people in their contributions talked about the stigma of women accessing health, and I was very aware of that at one of my very early meetings when I took on this portfolio with the Young Women's Movement, and that's exactly what they told me. And I recognise a lot of the stuff that Pam Duncan-Glancy has spoken about, and recognise, like she does, that that is not an appropriate way to treat women when they are accessing health services, whether if they are disabled. I would very much like to have a further conversation with Pam Duncan-Glancy on this to ensure that we can incorporate that as well as we can in the next phase of the plan. On a similar note, the comments made by Audrey Nicholl with regard to prison services. Like Audrey, I've visited Bella and found it a very inspiring place where it was giving women the opportunity to step back into life outside prison and also providing them with suitable health care. The final report does mention progress in improving health care for women in prisons by giving additional investment to health boards to deliver trauma-informed health care. But again, and we have a cross-ministerial group looking across justice and health care, so very happy to engage further with that group and Audrey Nicholl to ensure that we have the right connections with women in the justice system as we progress on to the next phase of the plan. Claire Adamson and others mentioned cultural barriers. I've been very pleased to be able to meet with AMA mothers in Glasgow on a couple of occasions to understand the work that they are doing to reduce inequalities with BAME mothers, whether they're asylum seekers or refugees in the Glasgow area and further afield. And I also attended a research outcomes event, which again looked at maternity care for refugees and asylum seekers, and there was some very powerful information within that, which again I think is very helpful for us to look at when we're talking about women's health. If I may return to abortion safe zones, I think Gillian Mackay's bill was a great example of where this Parliament worked incredibly well together. The committee stages were very probing, as Tess White talked about, but also when we were able to have conversations both at stage 2 and prior to stage 3, there was a very openness and understanding of positions where we were coming from, and I think that was a really good example of this Parliament working well, and I would hope we can have the same structure when we're looking towards the next phase of the Women's Health Plan, and I look forward to engaging with Annie Wells in your new role in that, and clearly welcome you along to the meetings that we've been having with Professor Glazier on a kind of 6-monthly basis. Gillian also made some points suggesting ways forward, which again, very happy to engage with to try and move things on. And I was very pleased that Alec Cole-Hamilton recognised the consensus across the Parliament. He too talked about the stigma and also mental health support, which we have taken forward a number of actions within the Perimental Health Peer Support Action Plan, and that supports practitioners but also peer support in supporting pregnant women, mothers and young babies and partners, fathers facing challenges such as loneliness and isolation. I do recognise we can always go further, but we have got that work ongoing. Yes, of course.
Gillian Mackay.
Partly to give the Minister a wee minute to get a sip of water. But does she also recognise that actually what we need to do is keep mums well throughout their pregnancy, to make sure that they are supported to have the best mental health they possibly can throughout that journey, so that when issues do creep up in postpartum situations, that there are already existing support mechanisms there for them?
Yes, I thank Gillian Mackay for that intervention. And last week I visited Home Start Glasgow in the south side of the city, and that's exactly what they have been doing, is supporting mums that are about to give birth all the way through to when the children are at primary school, and it is that combined support that they can provide. And I was very pleased to be able to listen and learn from some very powerful mothers telling me about the difference that had made from their own mental health perspective as well. I think if I may just touch on the neonatal situation and the decision that was being made there. The reason these decisions have been made is that we are doing this to give the babies who have been born at the extremes of prematurity the best chance of survival, and I believe that's what every parent wants. Evidence shows that these babies do best when they are cared for in large specialist neonatal units, which look after a lot of babies and have specialist staff services available on site to give them the best care. And as I said in the intervention earlier in this debate, this is supported by experts and by Bliss, the charity who represents neonatal families. If you don't mind, because there's a few things that I would like to go on to talk about. There was a lot of discussion with regards to remote and rural maternity services. And at a national level, we continue to take forward work to address the challenges faced by maternity services in rural health boards. Initiatives such as implementation of the Best Start and the introduction of continuity of carer, the development of community hubs and the increased use of Near Me that allows for remote consultations and appointments where appropriate, all intend to improve the delivery of maternity services in rural areas. And I recognise that representing Argyll and Bute, which is a number of islands which use these additional routes. And we particularly recognise the importance of patient transport and works commencing to recognise the importance of patient transport and to develop guidance on pre-hospital maternity and neonatal care and remote and rural interpartum transfers. And we will again consider any specific needs and challenges facing rural communities across Scotland. There was a number of contributions which talked about pre-eclampsia, and I note that it was recognised that the Scottish Government has invested into health boards to ensure that the test, which is an important tool in identifying pre-eclampsia, a condition which can be, as others have said, dangerous or life-threatening to pregnant women and babies. Our expectation remains that all NHS boards work to ensure that the recommendations on PLGF-based testing are implemented effectively and consistently, and we're working with NHS boards to navigate any local challenges to implementation. And also to Kenneth Gibson's mention of PBC, it's later, so Ms Mackay, I will understand, I will not explain PBC, but I was very pleased that in October Professor Glazier attended the Parliamentary Round Table, and we recognise that this liver disease that predominantly affects women. Are you wanting me to wind up?
You have time, Minister, if you're content to continue.
That's fine. I was just, the group heard personal accounts from patients living with PBC and discussed how treatment and care could be improved for those in Scotland with the condition. We absolutely recognise the importance of hearing directly from people living in Scotland as we look to develop the next phase of the Women's Health Plan. And Professor Glazier appreciated very much the opportunity to hear first-hand from those living with PBC and the clinicians supporting them. I'd also like to just touch on the points that Jackie Bailey made with regard to menopause services. When I was in Aberdeen during summer recess, I specifically heard about fantastic work that Aberdeen is doing around Migraine UK and supporting women and men that are living with migraine. And the work that they're doing closely between primary care and also pharmacies. And when I said, so this seems like an excellent way forward, what would be your next suggestion? So it is menopause. So it is absolutely on my radar, and it is discussions that I'm having. With regards to heart health, there's some incredibly important research work happening at Napier University, which again I am keeping across. As everyone said in this debate, it is our duty to ensure that every girl and woman, regardless of age and background, has appropriate and timely access to the information, support and services required to live a healthy life I'm just concluding. Thank you. It is a critical part of improving the health of Scotland. And I'm very encouraged that we've found some consensus today, and I hope that everyone in the Chamber that took part in this debate, and perhaps those that will read some of the contributions after, will continue to work together, because this is such an important thing, as we said at the start of the debate, for the health of Scotland as a whole. And I would be very happy to meet with people to talk further about their ideas and their contributions and their suggestions to ensure that we get the next iteration of this, the Women's Health Plan, as correct as possible. Thank you.
Thank you. That concludes the debate on the Women's Health Plan 2021 to 2024, progress and next steps. It is now time to move on to the next item of business. And we have a revised business motion. The next item of business is consideration of business motion 15430, and it's in the name of Minister Jamie Hepburn on behalf of the Parliamentary Bureau on changes to the business programme. Any member who wishes to speak to the motion should press their request to speak button now. And I call on Jamie Hepburn to move the motion.
President Officer, I'm very happy to move the motion in my name, which seeks to add a statement this week on Thursday, just after the scheduled questions that we have already agreed, which are education and skills questions. This upon the request from other parties, and of course, being the accommodating person I am, I was very happy to add that to the schedule, and with that I move the motion in my name.
Thank you, Minister. No member has asked to speak to the motion. Therefore, the question is that motion 15430 be agreed. Are we all agreed? Yes. The motion is therefore agreed. And we move to decision time, and there are 3 questions to be put as a result of today's business. The first question is that Amendment 15382.1 in the name of Annie Wells, which seeks to amend Motion 15382 in the name of Jenny Minto on the Women's Health Plan 2021 to 2024, progress and next steps, be agreed. Are we all agreed? Yes. The Parliament is not agreed, therefore we'll move to a vote, and there will be a short suspension to allow members to access the digital voting system.